speaking on the basic and advanced examination of the fetal skeleton. The components of this presentation include how to perform a basic screening examination of the fetal skeletal system, the indication of advanced examination, how to perform an advanced examination of the fetal skeleton, and then interpretation of findings of this advanced examination. Now, as we all know, the basic screening of the fetal skeleton, be it in the second or the third trimester, begins with measurement of femur length. As you can see in this image, when we obtain a femur length, the bone should be as straight as possible, such that both ends of the ossified diaphysis are clearly visible. The focal zone should be at the level of the femur shaft. There should be optimal magnification so that you see the ends of the femur very clearly and know where to place the calipers. The longest axis of the diaphysis is to be measured. The ultrasound beam should be such that it falls at an almost 90-degree angle to the femur shaft. One must insonate the thigh from the anterior approach, and why I will just show you shortly. Please remember to place the calipers at the ends of the ossified diaphysis without including either the epiphysis or this spur artifact. Now, when we look at the femur, even by just one glance during the examination, we can assess whether the bone is normally mineralized or not. This is because when a femur is normally mineralized, we see this distal shadowing. So we are not able to see the structures distal to this femur in the leg because of this shadowing from a normally mineralized femur. And this is what a normal mineralized femur looks like in the basic exam. Now, studies have seen that short femur length is sometimes not because actually the femur is short, but what happens is that in as many as 13% of cases, there can just be erroneous measurement of the femur length. And what we thought was a short femur might actually turn out to be a normal femur when examined by somebody else. So it's important that we measure the femur in the correct plane and know how to place the calipers. We can get a false impression of femoral bowing. As you see in this case, there appears to be mild bowing of the femur, and this can happen when we are insonating the femur from the lateral aspect of the leg. As you see here in this radiograph, the femur is not like a straight bone. It has its contours. If we insonate it dead laterally, we can get this mild bowing kind of appearance, as you see here. And if we were to measure the femur in this fashion, we would end up underestimating the femur length. The bowing becomes even more conspicuous if we insonate the leg or the thigh from the medial aspect, because the medial part of the femur bone is even more concave. So it's best to have an antero-external approach while insonating the femoral shaft so that you get the femur as a complete perfect straight line and don't end up making a false call of femoral bowing, or don't underestimate the femur length. How can we overestimate the femur length? This is when, if you include this spur artifact, the spur artifact, if it's included in the measurement of the diaphysis, would result in overestimation of femur length. So these are the pitfalls that you must avoid while examining the femur. Now, in the basic examination, we don't measure other bones, but we eyeball all the 3 segments of all the 4 limbs. As you see here, we look at the lower limbs, the upper limbs, both the upper and the lower limbs. We look for the presence and absence of 3 segments. We look at the bones to see if they are normal in number, they are symmetrical on either side, look at their shape or contour, look at the alignment of the foot with respect to the lower leg. As we know, the foot is at 90-degree angle to the lower leg bones. We look at the carrying angle of the elbow, the normal relationship of the hand with the wrist. Remember, counting the fingers and toes is not a part of the basic examination as per ISOAG guidelines. Now, since limbs are dynamic structures, we must also always look for limb movements, that is flexion, extension at the various joints during the basic exam. Now, there are other components of the basic 20+2 plane approach which help us in assessing the fetal skeleton. First, when we look at the fetal head, we not only look at the brain, but we also assess the calvarium. We look at the head for its shape, again, simply by eyeballing. The normal fetal head has this rugby football-like shape. We can also have an objective measurement of the head by calculating what is known as the cephalic index. which is nothing but a ratio of the biparietal diameter to the occipitofrontal diameter expressed as a percentage. And normal cephalic index is between 75 to 85. When it is less than 75, we term it as dolichocephaly, and more than 85 is termed as brachycephaly and can be seen in certain skeletal dysplasias. Another indicator, again, of normal calvarial mineralization in this simple axial plane of the fetal head is this reverberation artifact, which we see distal to the normally mineralized calvarial bone. Because of this reverberation artifact from the normally mineralized calvarium, we are unable to see the non-dependent part of the brain, or the part of the brain which is just next to the transducer normally. Now just have a look at this skull for a contrast. First, if you eyeball this head, you would appreciate that the shape of the head is not rugby, it's kind of roundish. And if we were to measure the cephalic index, it was more than 85. So this was a brachycephalic skull. And note now how you can see the normal non-dependent part of the brain next to the transducer. This is because of hypomineralization of the skull bone. So there isn't that dense reverberation artifact, and that's why you're able to see the part of the brain next to the probe in the axial plane. So this was a fetus with osteogenesis imperfecta having hypomineralized skull bones, and as a result, this appearance of the head. Now, fetal skeleton is also assessed when we have a look at the sagittal section of the face. As you see here, we look at the fetal forehead, we can see the nasal bone, the maxilla, the mandible. Now, this is what a frontal bossing looks like. So a prominent forehead in a fetus with achondroplasia. Note how it is different from the normal forehead contour. Then sometimes in certain skeletal dysplasias, the nasal bone can be present, but there can be flattening of this nasal bridge, which is termed as binder facies or binder phenotype, as seen here. We also see the spine in the normal basic examination of the skeletal system. Remember, the normal spine has this classic tram track or railroad kind of appearance, where the anterior part of this tram track is formed by the ossification central of the vertebral bodies, and the posterior part by the neural arch elements. Now, if there's a problem in the posterior arch elements, it's usually suggestive of spina bifida, open or closed, whereas in this anterior part of the arch or the vertebral bodies, we can look for segmentation anomalies. That is, we can look for fusion of these vertebral bodies as seen in block vertebrae. What you also need to appreciate here is that the normal vertebral body height is more than that of the adjacent intervertebral disc. Whereas in cases with platyspondyle, where there is flattening of the vertebral body, the intervertebral disc height would end up being more than that of the adjacent vertebral body. So this intervertebral disc would become wider as compared to the vertebral body in case of platyspondyle. Also, we can appreciate this normal sacral tapering, and the sacral vertebrae extend in between the iliac blades. So presence of the ossification center of the sacral vertebral bodies between the iliac blades helps us in ruling out things like caudal regression syndrome. The coronal plane of the spine, as you see here, the coronal plane of the lumbosacral spine is good to rule out curvature abnormalities, especially scoliosis. Longitudinal sweep is also a part of the 20+2 plane approach. As you can see in this longitudinal section of the fetus, this is the head, the chest, the abdomen. Normally, the chest and abdomen are in proportion to each other. However, in this longitudinal sweep, you can see that this is the head, chest, and the abdomen, but the chest appears narrow as compared to the abdomen. So this is how the appearance of the chest looks like in a fetus with thoracic hypoplasia secondary to lethal skeletal dysplasias. Again, this appearance of the fetal chest in the longitudinal sweep can also be a pointer to a possible skeletal abnormality of significance. Now, extremities can also be visualized. In fact, they are visualized very well in the first trimester because at that time there is adequate amount of amniotic fluid around the limbs and there is hardly any bone shadowing. Just as we see in the second and third trimester, we need to look at all the three segments of both the upper and the lower limbs. As you can see in this clip, we can easily see the humerus, the radius, the ulna. The radius is the shorter bone which is placed laterally, that is towards the thumb, whereas ulna is the longer bone of the forearm towards the little finger. As early as the first trimester, we can appreciate the ossification in the metacarpals and the phalanges as seen here, and even count the digits very easily. So you can count 4 fingers and the thumb here very easily in the first trimester. We can also have a look at the lower limbs as you see here, both the femora, the tibia and the fibulae, tibia being the medial bone and fibula the lateral one. And we can also appreciate the normal orientation of the feet with respect to the lower limbs. Again, one must remember to look for movements of both the upper and the lower limbs in the first trimester as well. Besides the long bones, bones like clavicle, mandible, ilium, scapula also ossify by 12 weeks, and metacarpals and metatarsals are also seen at the time of the first trimester scan after 12 weeks. One must look at the fetus in totality, that is, see the attitude of the fetus along with the bones. Now I'll show you this clip, and you can appreciate in this high resolution image taken with a linear probe in the first trimester at 13 weeks, you can easily appreciate polydactyly, post-axial polydactyly in this case. There are 5 fingers here and the 6th thumb in a different plane. So the thumb is here in a different plane and the 5 digits here. So as early as first trimester, you can count fingers very easily and make a call of polydactyly. Coming to the fetal head in the first trimester, just as in the second trimester, the calvarial bones are well ossified and seen at the time of the NT scan after 11 weeks, as you see here as echogenic bones, separated by these sutures. Of course, in the first trimester, they're not as mineralized as in the second trimester to cast those reverberation artifacts. So you will see the near part of the brain also in the first trimester normally. Please remember that before 10 weeks, you should not end up making a call of absence of calvarial bones, because at that point of time, the calvarial bones are not ossified. So this is a normal appearance of the skull with non-ossification of the calvarial bones at 9 weeks. Just as we see in the second trimester, in the first trimester, we can see the spine in the coronal plane, as we see here, the tram track appearance of the posterior arch elements, and we can see the spine for curvature abnormalities even in the first trimester. This is a sagittal section, again showing the vertebral bodies anteriorly and the posterior arch elements posteriorly. Sometimes in the first trimester, what happens is that we can see the ossification center of the sacral vertebrae, that is the sacral body, but we can't see those of the posterior arch elements. So as long as you see the ossification of the vertebral bodies, it's all right, and one should not end up making a call of sacral agenesis just because the posterior arch elements have not got ossified, because they sometimes ossify later in the second trimester. So as long as you see the ossification of vertebral bodies of the sacrum, it is okay in the first trimester. Coming to the face, just as we see it in the second trimester, in the first trimester, we can assess the face for looking at the forehead, nasal bone, maxilla, mandible. When do we perform an advanced skeletal examination? The most common indication is when we see a femur less than 5th centile during the basic exam. And please remember that the 5th centile corresponds to 1.6 standard deviations below the mean. Also, if we see any other abnormality in the femur, for instance, bowing of the femur, or any abnormality in any of the other bones, that is what prompts us to do an advanced examination of the skeletal system. If a couple has a previous child or a pregnancy with skeletal dysplasia, or a family history of skeletal dysplasia, this is also an indication to perform an advanced skeletal examination of the fetus. Now, whenever you see a short femur, before panicking that there is a skeletal dysplasia, please remember to also check the height of both the parents, because sometimes it's just a case of familial short stature and nothing else. Now, what are the various measurements? There are certain measurements that we perform in an advanced examination. These include measuring not only both the femur, but all the long bones, so as to assess the pattern of shortening. So if only the proximal bones of the limbs are affected, that is the proximal humerus or the femur, then it is rhizomelic shortening. If the middle segment is affected, it is mesomelic. And if only the distal segment is affected, it's termed as acromelic shortening. It's important to have this differentiation of patterns of shortening, because accordingly the differential diagnosis would vary. Micromillic shortening is when the entire limb is shortened proportionately. Then besides femur length, we calculate a ratio between the femur and the foot length, which is termed as femur foot length ratio. We look for the femur length to abdominal circumference ratio. We look at the thoracic circumference in the axial four chamber view and can also calculate the lung volume using 3D ultrasound. Now, why do we do all this? This is done first to understand if the femur shortening is truly because of a skeletal dysplasia. Because remember, a femur less than fifth centile can also be due to other causes like fetal growth restriction. It can even present first only with femur shortening and then reduction in centiles of other parts of the biometry. Also, once you are sure that it's a skeletal dysplasia, in terms of prognostication, one has to try to attempt to differentiate lethal from non-lethal skeletal dysplasias. So these two purposes are served by taking certain measurements and ratios. Now, if femur length is more than 5 millimeters below the -2 standard, now remember I said fifth centile is equal to -1.6 standard deviation. If femur length is more than 5 millimeters below the -2 standard deviation, which all roughly corresponds to around 4 standard deviations below the mean, then there is a high probability that this femur shortening is because of skeletal dysplasia, because this is marked femur shortening. So it's more likely to be due to skeletal dysplasia rather than due to other things like fetal growth restriction or aneuploidies like trisomy 21. This, along with a femur foot length ratio less than 0.9 or a femur length to abdominal circumference ratio less than 0.16, is suggestive of skeletal dysplasia. So when you see a short femur, please look at these other ratios as well, so as to be more sure or to gather more evidence so as to make a confident diagnosis of skeletal dysplasia. The next step would be prediction of lethality. Any skeletal dysplasia which presents in the first trimester, along with nuchal translucency, things like abnormality in skull shape, abnormal mineralization of the skull, small chest, is highly predictive of a lethal skeletal dysplasia. In fact, studies quote that a skeletal dysplasia with increased nuchal translucency thickness tends to be lethal in approximately 85% of cases. So any skeletal dysplasia with an early onset would tend to have a lethal outcome. Now, when you come across a skeletal dysplasia in the second or third trimester of pregnancy, there are a host of measurements that you can take in order to try to make a more confident diagnosis of lethality. Please remember to try to measure or try to satisfy as many points as possible, because more the number of points in your favor, more likely are you to be making a correct diagnosis of lethality. That being said, it's not always possible to identify lethality due to a skeletal dysplasia in the antenatal period by ultrasound alone. And sometimes postnatally, you might end up finding individuals who were thought to have a lethal kind of skeletal dysplasia surviving into childhood. So the various points which we can use in our favor include measuring the thoracic circumference, which if it is less than fifth centile for that period of gestation, it is measured at the level of the four-chamber view, is suggestive of thoracic hyperplasia or pulmonary hypoplasia. Lung volume is typically measured using 3D ultrasound, and if it is again less than fifth centile for that period of gestation, it would be suggestive of pulmonary hypoplasia. A thoracic circumference to abdominal circumference ratio less than 0.6 is again predictor of lethality. A short thoracic length, which is measured in a coronal plane from the base of the neck to the diaphragm, is also another predictor. When we look at the ribs in the four-chamber view, normally the ribs encircle more than 70% or more than two-thirds of the thoracic circumference. If it is less than that, that is another predictor. Then, when the chest or the thorax is narrow in case of a lethal skeletal dysplasia, the heart tends to appear bigger. And so a heart to chest circumference ratio more than 50% is another predictor that has been used to predict lethality. And finally, as I said, a femur length to abdominal circumference ratio less than 0.16 is suggestive of a skeletal dysplasia. But when it comes with a combination of polyhydramnios, then it is suggestive of pulmonary hypoplasia and again a predictor of lethality. In the advanced examination, after performing certain measurements, we start looking at various parts of the skeleton one by one. Starting from the head, we see the sutures. Now, why do we look at the various bones? This is because we try to gather information so as to establish a prenatal phenotype. And this information is very important for the geneticist and the lab if they are to give us an accurate genetic diagnosis. Not only does ultrasound, but of course, postnatal examination has the vital role to play in elucidating the complete prenatal phenotype in skeletal dysplasia. Now, starting with sutures, if you are looking at the skull from the top, and this is the anterior, this the posterior, then anteriorly we have the metopic suture, which continues into the anterior fontanelle. On either side is the coronal suture, and posterior to the anterior fontanelle is the sagittal suture. When we look at the skull in the lateral view, we of course can't see the metopic suture, but what we can appreciate here is the anterior fontanelle, the coronal suture, which ends up in the sphenoid fontanelle, and then the squamosal suture, which passes through the temporal bone and ends up at the mastoid fontanelle. And finally, we have the lambdoid suture between the posterior fontanelle and the mastoid fontanelle. So these sutures and fontanelles separate the various bones, the frontal bone, the parietal, temporal, and the occipital bone in antenatal period. We can look at the sutures even on grayscale. And why looking at sutures is important in a suspected skeletal, in a case of suspected skeletal dysplasia is because there can be fusion or craniosynostosis in certain skeletal dysplasias. To look at a suture in grayscale, the ultrasound beam has to be at right angles or at 90 degrees to the suture. Here, this is the anterior part of the head. This is the thalamus. So this is anterior, and one can appreciate the coronal suture between the frontal and the parietal bone. In this case, this is the posterior part of the head, and one can appreciate the lambdoid suture between the parietal and the occipital bone. Sutures are also window to the brain. From the sutures, the ultrasound beam can pass posteriorly, and one can look at the brain. In case there is premature fusion of sutures, this visualization of brain would be impaired, as you see in this image taken from this paper. As you can see, this is a sagittal section of the head. You can appreciate the corpus callosum. This is the anterior part of the head, and this is the posterior part. And there is dense shadowing in the posterior part. This is taking place because of fusion of the sagittal suture, and this is known as the brain shadowing sign. So if you're confident in taking images with when you see the face, you can also should try to look at the brain. And if you're not able to see the brain for some reason, you should start thinking in terms of fusion of sutures, as I did in this case. Here I was seeing the sagittal section of the face, but no matter how hard I tried, I could not see the brain, and this was because this fetus had fusion or craniosynostosis of the metopic suture. Sutures are actually seen better on 3D, as you see here. This is a second trimester fetus, and you can appreciate part of the coronal suture here. In order to acquire sutures on 3D, if you have, you can do it in plane sagittal transverse. The acquisition in sagittal plane is done when the face is in the median face profile view. And in the transverse plane, when the probe is at the level of the biparietal diameter, you can do an acquisition. Coronal acquisition is not mandatory, but if you want, it can be done by placing the probe at the level of anterior to the ear. The rendering mode that we typically use to see the sutures is the surface or the maximum mode. And this is the first trimester fetus. In the first trimester, you can see that the sutures are very wide. This is normal. Sutures are more wide in the first trimester and less so in the second and third trimester. So it's important to be familiar with the normal appearance of sutures throughout the gestation before you make a call of craniosynostosis. And this is that fetus with metopic synostosis, which I just showed you in the previous slide. So you can see here the fusion of the metopic suture, the craniosynostosis of the metopic suture here. Then we have the examination of the orbit. The orbits can be seen in the axial plane. We can measure the orbits, and this includes measurement of the interorbital diameter, as you see here. Normally, this interorbital diameter is equal to the ocular diameter. So you can fit one globe in between the two orbits. If there is hypertelorism, that is the orbits are far apart, you will be able to fit more than one globe here. And if there is hypotelorism, that is the orbits are closer to each other, you will not be able to fit one globe in between. The biocular diameter is calculated by measuring this distance from outer to outer between the lateral margins of the orbits. Then the mandible can also be assessed in the profile view, and it's important to assess the mandible because in certain skeletal dysplasias, there is micronathia or a small mandible. In fact, more than 30 angles and indices have been described to identify micronathia, one of which is the inferior facial angle. I'll just be discussing the common ones. As the name suggests, the inferior facial angle is measured by first drawing a line perpendicular to the root of the nose, and the second line comes from the chin and touches any of the lips which is more conspicuous. In this case, it's the lower lip, and this angle in between is the inferior facial angle. An angle less than 49 degrees is suggestive of micronathia. Similarly, we have the frontonasomental angle. As the name suggests, line is drawn from the frontal bone to the nasal tip and from nasal tip to the mentum, and the angle in between would be the frontonasomental angle. When it is between 100 to 134 degrees, it is suggestive of micronathia. And then we have a measurement which is taken in the axial plane of the mandible. It is termed as the jaw index. So this is the axial plane of the mandible as you see here. This is the anterior part, the region of the symphysis mentae. And this is the posterior part, that is the rami of the mandible. So what we do is we measure the antero-posterior diameter of the mandible at its widest, that is at the level of the rami. And this diameter is divided by the biparietal diameter and multiplied by 100 to get a jaw index. So a jaw index less than 23 is suggestive of micronathia irrespective of the gestational age. We can also look for micronathia in the first trimester. As you can see in this mid-sagittal section of the face, here the micronathia is obvious. But sometimes you can appreciate the micronathia just by looking at this premaxillary or the retronasal triangle view. The normal retronasal triangle looks like this. It has this normal gap termed as the mandibular gap seen in between the rami of mandible. When there is micronathia, the mandible is receded posteriorly, and so you won't be able to see the normal mandibular gap, but instead you will see the anterior part of the body of the mandible and lack of mandibular gap in case of micronathia in the first trimester in this retronasal triangle view. Coming down to the neck, in the lower part of the neck, we can see the clavicles in the axial plane, as you see here. These are both the clavicles, which have a kind of S shape normally. In certain skeletal dysplasias, for instance, cleidocranial dysplasia, the clavicles can be absent or hypoplastic. You can see here, this was a case with hypoplastic clavicles. The normal S-shaped contour is not seen. And if you were to measure this clavicle, it would fall less than 5th centile for this period of gestation. Clavicles can also be assessed again in the axial plane in the first trimester, as you see here. Then scapula is another bone that we need to look in the chest. Here you just see a clip of the fetus and you can appreciate just the presence of the scapula behind the ribs here. This axial plane just helps you get an idea whether the scapula is present or not. But if you are to look at the scapula in detail, you need to do it in a sagittal plane. You take the sagittal plane of the spine and move more laterally towards the shoulder, as I've done here. And you can appreciate this triangular bone, which is nothing but the normal scapula, which can even be measured so that you can assess whether it is hypoplastic or not. Again, certain dysplasias like campomelic dysplasia have an absent or hypoplastic scapula. Sometimes this scapula can be placed high up, that is, from its normal position, it can be placed higher up when it is termed as sprangle shoulder. 3D is a very good tool to have a look at the scapulae. As you can see here in this rendered image, you can easily identify the position and the presence of the scapula on a rendered 3D image. Scapula can also be seen in the first trimester. As you can see in this coronal image of the fetus, this is the spine, the iliac blades on either side, and this structure that you see here is the normal scapula. So it can even be identified in the first trimester. Coming to the appearance of ribs, As I said earlier, normally ribs occupy more than 70% or two-thirds circumference of the chest at the level of the four-chamber view. This is also the level we can measure the thoracic circumference to get an idea about pulmonary hypoplasia. Now, this is a fetus with a lethal skeletal dysplasia. And if you look at the ribs. The ribs are falling short here. They're not even enclosing 50% of the circumference of the thorax. So this is what short ribs look like in comparison to normal ribs here. Ribs can again also be assessed very well using 3D as I've done in this volume rendered image in the maximum mode. One look at the ribs and you can easily appreciate that the 12th rib is hypoplastic here on both sides, something which would be very difficult to appreciate in a simple 2D image. Then spine is assessed definitely on grayscale, but if there's some abnormality or we want to look at the spine better, we can show it in a panoramic fashion in the 3D as you see here. And here you can appreciate the presence of this hemivertebra, that is just half of the vertebral body seen here as compared to the other vertebrae. So you can see not only the vertebral bodies, but also the posterior arch elements using 3D. The pelvis, this is a pelvis in a fetus in the second trimester. You can appreciate the ossification centers of the sacral vertebral bodies as well as the posterior arch elements in between the iliac blades. So this is a normal sacrum. In the first trimester, you can identify the iliac blades. And if you try to get a 3D rendered image, you can see some part of the sacral vertebral bodies. So if you are able to see the sacral vertebral bodies between iliac blades, it rules out complete sacral agenesis even in the first trimester. One can get a very panoramic view of the limbs using 3D in the first trimester because, as I said, there's a lot of amniotic fluid, as you see here. And one glance here, and you can see in this surface rendered image that the limbs are normal. You can reassure the parents in this case. Whereas here in this rendered image, you don't see any of the four limbs. And this was a fetus with tetraamelia in the first trimester. So we can use ultrasound to our advantage in order to show things much better. If there's an unusual limb anomaly, 3D can help us in understanding how the limb is oriented. As you see here, this is a fetus with genu recurvatum, and you can appreciate how the knee is hyperextended. Normally, this should have been a straight line. The leg is normally straight. Here it is hyperextended. So it helps us in understanding.
5 more minutes.
Yes, I'm almost coming to the end of my presentation. So you can use 3D ultrasound to your advantage to see the abnormal orientation of limbs as well. And finally, while you're looking at the skeleton in great detail, please do not forget to look beyond the skeletal system, even in a fetus with skeletal dysplasia or a limb abnormality, because often there are multiple more than limb. There can be abnormalities in the brain, in the heart, because the causes of skeletal dysplasias can not only affect the bones, but can affect other structures as well. So don't fall prey to the satisfaction of search error. Don't be very happy that you've seen the skeletal system and that's enough. Please look beyond the skeletal system as well. So to conclude, I hope you understand now that femur length is the first checkpoint, which helps us in directing towards a possible skeletal anomaly. But please remember to measure the femur length correctly because we don't want to end up making a false positive call of short femur when it's actually a normal femur. And advanced examination of the fetal skeletal system involves assessment of various systems, both part of the axial and the appendicular skeleton, and liberal use of 3D ultrasound. Now, if you're doing a basic examination, your role is just to identify a skeletal abnormality and refer a patient. However, if you're doing an advanced examination, not only do you try to come to a diagnosis of skeletal dysplasia, but you also have to provide a detailed prenatal phenotype so that a genotype is assessed correctly. And if possible, try to comment on lethality or non-lethality. Remember, your diagnosis should never be based on one single finding. You have to collect all the findings and take them into account so that you give a best possible diagnosis to your patient.